Good evening, ladies and gentlemen. Welcome to the City of York Council Health and Adult Social Care Policy and Scrutiny Committee. It's Tuesday, the 2nd of November. Joining us at the table, along with members of the committee, include Jamila Hussain, the Director of Prevention and Commission, Councillor Carol Runciman, who's the Chair of the Health and Wellbeing Board and Executive Member for Health, and Peter Roderick, who's the Consultant in Public Health with the Council, and also jointly with the Vela York CCG. And Peter's also helping out in lieu of Sharon Stoltz not being available this evening. Thank you very much, Peter. We have apologies from Councillor Barnes. There's no substitute this evening, but otherwise we've got everyone else here. Do any members have any declarations of interest other than listed at all? No, thank you. We don't have any members of the public registered in public participation this evening, so we can go straight into the first of our, well, actually the minutes first. So the minutes from the July meeting are within the agenda. Are members happy to agree that these are accurate reflection of the meeting, those members who are here? Yeah, thank you. Thanks very much. So we'll go to agenda item 4, which is the update on the Foss Park Hospital, including details of the most recent CQC inspection. And we've got participants, colleagues from TZESC and Weir Valley's NHS Foundation Trust online with us this evening. Naomi Lonergan had some difficulties with the car, so she's joining us on the Zoom call as well. So we've got Naomi Lonergan, who's the Director of Operations, and also Martin Dale, who's the Strategic Project Manager. And we may have Dr. Olusogo joining us as well at some point online. Good evening, colleagues.
Good evening.
Good evening.
Hello. Would you like to give a brief introduction to your report, please?
Yes, thank you, Chair. And apologies I couldn't attend in person on this occasion. I very much hope to, as and when I'm invited back to present to the committee. The paper that we have covers progress and updates in relation to Foss Park and CQC activity within the Trust and Foss Park specifically. Martin Dale will start the briefing about the Foss Park update, and then I'm going to take over to update you on the CQC inspections from January 2021 to the current date. So Martin, if you could give us the update on Foss Park, please.
Yep, certainly. Thank you, Naomi. Thank you, Chair. We previously sat at Scrutiny Committee back in February 19, which seems a lifetime ago in so many ways, pre-pandemic and pre the opening of Foss Park. So hopefully the paper that you've got in front of you summarises the updates since that time. You will all remember that Foss Park was a very collaborative project with a massive amount of inclusion work with our service users, carers, stakeholders. There will be people around the table who are very much involved at various stages. And so really this is just an update on where we've got to. You will likely recall that we are a 72-bed hospital providing 2 adult single-sex wards and 2 older persons wards, 1 for people with dementia and 1 for people with mental health conditions, such as severe depression, anxiety. We became operational April 2020, 21st of April 2020, 1 week ahead of schedule. Fair to say that that was some challenge. But we certainly opened ahead of schedule, and I think it's also fair to say that within a week or so of opening, it felt like we'd been open for a long time. Such was the commitment of our staff to make things work. All 72 bedrooms are single bedrooms with ensuite facilities. It is regrettable that we have not been able to show any of you around the patient areas of the wards since we opened, or indeed just pre-opening, and that was purely down to the pandemic and our infection control measures. Otherwise, we would have had some official opening time and chance to have a proper look around and see what we've all been doing. Important part about the spaces that we've designed is that all of the bedrooms are have ensuite facilities, all have a garden sort of view. All the bedroom corridors are one-sided with garden views and views of green space on the other, and no two rooms face each other. Hugely important in reducing tension, reducing anxiety. Window seating in the corridors to help people get out of their rooms, even if they're not at the early stages of admission comfortable in using the day spaces. Lots of different day spaces, it has to be said. So we can hopefully cater for people who are happy in a group setting, people who are happy on a more individual footing, but provide a range of therapies using a range of different sort of forums. As you will recall, the build is a Cqc build on a piece of land that Cqc bought. It's a £40 million build in the end, with VAT fees, land purchase, and it was purchased through the internal cash reserves within Cqc through a very closely managed capital fund. Having that building as ours, with our control over it, means that we can maintain it properly to the standard required and develop it as time goes on. And that's something of a challenge in our previous buildings because of the leased arrangements that we had. I've included some photos in the report of the entranceway, one of the many garden spaces, and also some of the day spaces. It's fair to say, and I've kind of put it in the report, the entranceway is not the artist's impression, although it comes very close to what was originally planned. And I think people expected it would look very different in real life. Thankfully, it has certainly met the architect's brief. We've talked about service user and carer involvement. We had over 60 design workshops involving service users and carers, and that really helped us hone down not what we want to build, but what people need when they are experiencing an inpatient stay. And that really changed our thinking about a number of things. Things that we wouldn't have been able to do in a building if we hadn't started from scratch. You will all by now know that there are 4 wards at Foss Park called Ebor Ward, Minster Ward, Waldview Ward and Moorcroft Ward. The original naming process was hugely democratic, based on a focus group and a coaching approach of narrowing down acceptable themes, acceptable terms, acceptable language. But it was found within older person services that the names of Moor Ward and Wold Ward are very difficult to articulate for anybody with a cognitive difficulty, Wold Ward particularly. So the names later changed to Moorcroft and Woldview, and those have stuck. And again, we involved service users and carers very much at the heart of that refocusing work. I've included a little bit in the report about bed management. It's quite hard to talk about bed management these days. Since the pandemic struck, the pressure on care homes, residential homes, the delayed transfers of care positions for all health providers, it's very hard to use a singular set of data to illustrate how things are done. But compared to the report that I put together in February 19 for you, for the committee, our bed management has improved further still. So, for instance, in adult services today, adults and older services today across North Yorkshire, we have 12 vacant beds at 3 o'clock this afternoon. So we are running with some capacity, but I think Naomi would absolutely agree, it is extremely tight, tighter than when we set off on the Foss Park journey, tighter than when we opened. And it takes a lot of proactive management to make sure that we've still got local capacity for local people. Foss Park accommodates service users from York and Selby, as Bootham did before us, and as Peppermill Court, Meadowfields, Acombe Garth, etc. did. But we also accommodate people from Harrogate, and Harrogate provision was factored into the bed calculations. At Cross Lane Hospital in Scarborough, there were 2 extra beds that were potentially available to us should we require more capacity. So we've managed the beds across North Yorkshire as closely as we can. We keep people as local as we can. That's not always possible, but we do everything we can to make sure that that is the norm and that is what is expected. Leading on to Naomi's element about the Care Quality Commission, I would just finally say that for any hospital to be given an operational start has to be registered with the CQC, and our CQC registration process we could only describe as utterly unique. We had to manage the process remotely because of the pandemic, and that involved literally pushing a laptop with a webcam on a clinical trolley round the whole site and stopping at various points as the inspectors needed to sort of catch up on what we were doing about each aspect of it. It was a very strange but very full registration process, at the end of which we received very positive feedback from the CQC, and we got our registration with no outstanding issues at that point. So a very proud moment for everybody that was involved. And now I'll hand over to Naomi to talk about the CQC feedback that we've recently received.
Okay, thank you, Martin. So the report highlights the core inspection into acute and our PICU wards in the Trust, which are in Middlesbrough and Darlington, which occurred in January of this year. So in January, a core inspection into the acute and PICU wards was held, and 3 wards at Rosebery Park in Middlesbrough were reviewed alongside 1 ward at Cross Lane Hospital in Scarborough and 1 ward at West Park Hospital in Darlington. From this inspection, the CQC had concerns about our risk management processes, which they felt were complex and difficult to follow. And due to those concerns and subsequent enforcement action, the CQC rated our acute wards as inadequate for both safe and well led. Several actions were taken to address the concerns, and they're highlighted within the report. The actions included rapid quality improvement events being held to look at how we can improve risk management systems and introduce ways to simplify processes, very much focused on supporting staff to know what they are required to do, how they record, and how to do good quality risk assessment and management. Every inpatient record was audited across the Trust to make sure there was an up-to-date risk assessment, and that's now being integrated into our quality assurance schedule, which happens weekly. Masterclasses and support for staff using the new process were introduced, and we now have 100% of inpatient admissions where we address risk using the new safety summary safety plan. We're currently also reviewing our community safety summary and safety plans across all specialties in North Yorkshire and York and across the Trust, and we're making good progress with that. We've updated the supportive observation and engagement procedure and also introduced improved training for staff and a new practice development team that is now situated on our inpatient wards to drive the quality of our risk management and care planning. All staffing has been reviewed, and the board has also approved additional investment for frontline staff posts, which I'll come on to. From an assurance and oversight perspective, we've provided assurance to the Care Quality Commission that we've got effective systems now in place in our wards to help keep patients safe. But we also know that further improvements are underway and still need to be made. The Trust's improvement programme is being overseen and reviewed by an external quality assurance board, and that includes representatives from NHS England and Improvement, commissioners and the CQC. A new quality assurance schedule was launched in April, and that includes an ongoing supportive audit programme. And we also include directors' visits monthly, which is focused on learning from incidents. A re-inspection then took place in May of this year following that core inspection in January, and on the 27th of August the CQC published that report. The focused inspection was to see if improvements have been made, and the CQC rated our acute wards as requiring improvement. The inspection took place over 9 wards, and this time included wards at Foss Park Hospital. Positively, the CQC no longer have significant concerns relating to risk management of service users in our care. However, there is further learning and improvement required that is also highlighted in the report. We recognise there's a lot more work to do, and we're going to continue to embed improvements across our trust. That includes a range of activities, including new technology, digital solutions, and making sure that that has a positive impact on patient care. We've also made the significant investment commitment that I've already referred to, and in total across the trust and including our forensic services, that is over a £5 million investment. In addition to the core inspection, we've also had 2 Mental Health Act inspections from the CQC in 2 of our wards into Foss Park Hospital. They have been into Ebo ward, which is our female adult acute ward, and into Ward View, which is our older persons organic ward. Learning areas identified included some estates issues, most of which were rectified on the day of identification, improvements in carer communication, improving the quality of the safety summary and intervention plans, recording of interventions, and unfortunately a patient reporting items being lost or stolen whilst on the ward. Positive feedback was also provided from carers about the environment, links to local services, and the introduction of practice development approaches. The CQC also commented on the ongoing provision of Section 17 leave for inpatients with all COVID-related safety measures in place. So in conclusion, there's been some positive improvements to the quality and safety of patients on our acute wards, though there are still several areas of learning that we're working to address in the weeks and months, and the development of Foss Park Hospital has been a really positive step forward in the delivery of quality and patient care. I'm happy to take any questions on the report. Thank you.
Thank you, Naomi and Martin. And I'd just like to welcome online as well Dr. Tolu Olusoga, who's joined us and may help to answer questions that members might have as well, I guess. I'll open it to questions on the floor. Councillor Taylor first, Councillor Heaton.
Thank you, Chair, and thank you for the verbal report accompanying what I thought was quite an honest report in the papers, which I thought was quite refreshing. You know, it talked about the good stuff and the bad stuff and what you've done to try and make things better. I think the council could learn a lesson from that kind of reporting, but well, that's for another time. I do have 2 questions, Chair. The first is looking at this investment in extra staffing, which is on page 16 of the papers. 5.4 million, I know it's trust-wide, but it's still a huge amount. So I'm sort of trying to get a sense of what that looks like in reality. But what do you get for that money across your different sites? And how is recruitment going, you know, to make the most of that investment? That's my first question. Cheers.
Okay, thank you. If I could come in and respond, I think the investment extra staffing, you're right, that's the trust-wide average. I think what we're looking at is a recurrent, and please, this is an approximate cost into across North Yorkshire and York would be around 1 million per annum. What that is intended to secure on the wards is additional administrative support so that we're releasing time to care of our nursing and support work staff so that that is maximised on the wards and increased time is spent with patients. That's also to invest into practice development support. So that's been key to driving the improvements that we've seen so far and will be key to making good progress on where we've got to so far as well. There's also additional nursing capacity within that spend that is planned. In terms of progress, we're early days, so obviously I'd be happy to come back and give an update at a later date in terms of how we've progressed with this. We are in the stages of recruiting, and unfortunately, as we know, workforce in a number of sectors in health and social care is quite challenged currently. York, historically, whilst we have challenges compared to other patches across the locality, you know, we can be quite successful in terms of our recruitment. So it's about how we make our services attractive to candidates to newly qualified staff. And we have a number of plans in place to do that. And we work very closely with our nursing training colleagues in York and in the university in York St John.
Thank you. Can I do my second question now? Yeah.
Can I just provide some additional information to that, which might be helpful in terms of context? It's Dr. Olusoga here. Just to add into what Naomi has mentioned, we've also had some challenges historically with medical inputs in terms of actual having people bumps on seats and people doing the job. And over the last 18 months, we have actually recruited 4 consultants, such that we've gone from having 7 vacancies to actually just 2.5 now, 2.5 full-time equivalents. So actually, we've done quite a lot of work over the last few years to try and address some of the challenges within the service.
I mean, it does sound genuinely positive. I don't say that very often either. About many things. My second question, it might link to this, but I was surprised to hear, and correct me if I've misheard this, that you've currently got 12 vacant beds at Foss Park. Did I hear that correctly?
Hi, it's Martin. Sorry, no, that's not correct. As at middle of the afternoon, we had 12 beds across North Yorkshire and York. So that is Foss Park, Springwood Dementia Unit in Malton, and our Cross Lane, our 3 wards at Cross Lane. And what we do is we manage the North Yorkshire beds as a whole. Yeah. In that, we try everything we can to keep people as close to their local unit as they possibly can be. So yeah, and we look at beds every day, every morning, every afternoon. We have capacity calls and we link with the on-call structure about what's where. And we've recently, as a trust, built in a much more robust bed management system, which has localised bed managers too. Again, as Naomi would say, that's early days, but very positive work in progress, I think.
Thank you for the correction. If anything, it sort of lends itself nicely to what I was hoping to get into, which is, well, the thing that made me want to ask this question was the words unnecessary admissions. Now, I know what you mean by that, and I know it's not a loaded term, but I'm trying to sort of get a sense here. Is there much tension between what will be your clinical thresholds for someone to have a bed and what would-be patients might think is enough to merit having a bed? And I ask that question totally supporting the whole idea of services in the community, which we need, and I do know that services in the community have improved. But even with that in mind, I'm assuming there's still a bit of a tension there that you need to manage between expectations and your capacity.
Yes, I can certainly come in on that if that's okay with you, Naomi and Tolu.
Sure.
I think it's an absolutely fair question and a fair point. And as you rightly say, we've certainly not loaded that language in the report. There are always tensions that crop up between what somebody is expecting or demanding and what is clinically acceptable. Our job in managing the bed resource for the trust is for the locality is multifold. But within that sort of formula of how we need to work, we have to think about that resource doing the most good for the correct people. And if we admit people who are not clinically requiring an inpatient stay, we potentially are blocking a bed for somebody who does. Now, there's some history to this. So in York, as we've previously discussed at the Scrutiny Committee for York, York was an outlier as a city for having so many beds. And some of that is long and old history in terms of having 3 psychiatric hospitals at one point, Bootham, Clifton and Naban. Some of it was around the move in the late 80s into the early 90s to build what were the community units for the elderly, Acombe Garth, Meadowfields, Cherry Tree, etc. When those units were built as part of the dissolution of the sort of institutional mental health beds, they were designed to accommodate people funded by both health and social care. By the time they were built, that social care element was not available, nor necessarily required in that way. But the health component continued and the buildings were there. So we had far more beds in York than would ever be seemingly required under a more sort of formulated, calculated approach. Because of that, there is an expectation across the city that beds would be aplenty. And when we did the calculation and the PRAMS work to work up the model of how many beds we needed for Foss Park, and how we needed to reverse the spend so that we were putting more money into the community and less money into beds, that became very apparent that there was a huge expectation. So there is certainly a tension sometimes, but hopefully our crisis teams, our older persons crisis teams, young persons crisis teams manage that tension very, very closely at that point of contact, and where we can and where it is indicated, we put in very extensive packages of home treatment to keep people at home as long as we can. The majority of our service users tell us they don't want to be in hospital and they do want to be managed at home. So working with that is certainly our focus. Naomi and Tolu, I don't know if you want to add to that.
No, that's fine. Yeah. Good summary. Thank you, Martin.
Thank you.
Thank you for that. I did have a supplementary, but I think you sort of got on to answering that as you finished your response there. Thank you very much. Thanks, Chair.
Thank you.
Thank you.
I do want to just ask a further question relating to the same topic. Obviously, historically, we have had some issues where we've had patients from York placed out of area. So since Foss Park opened, has that occurred, or does it occur? Just really wanting to pinpoint, are there any people that we are aware of that are unwell in our community that might not be able to access local inpatient care?
If I could come in on that, please, Chair. I think we do have York patients that have had an inpatient admission outside of Foss Park since the opening of Foss Park, and there are a number of reasons that sit behind that. In terms of where we would, an alternative where we would look if somebody couldn't access a bed in Foss Park, we would then go to our nearest area. So Cross Lane Hospital would be also used. However, the complicating factor is that we opened Foss Park during COVID, and the requirement for us during the COVID, which still exists today, is that we have cohorting areas on wards. And so we have to have hot areas and cold areas for each patient group that we provide services for. And this means that at times, if a patient is, for example, COVID positive, they may also need to go to another area to receive appropriate care and treatment in a way that manages the risk of COVID and provides them with the correct support. So it's very difficult in terms of looking at the numbers of admissions we've had, where people have had to be admitted to in comparison with pre-COVID requirements, because the wards are operating slightly differently to what they've operated previously. Hope that makes sense. Some sense.
Yeah. Can I come in there now?
Yes, please.
In addition to that, Chair, the other thing that has happened is, on the back of the pandemic, one of the key things we realized is that the need for mental health care has increased, and certainly in adult age group, we anticipate an increase of about 2/3 on what we would normally see. And some of that are people who've never really presented with mental health difficulties previously. And of course, some of that would translate into requiring inpatient stay. And that's part of the problem. Those aspects are quite difficult to predict.
Yeah. Yes, and it's fair to say, Tolu, isn't it, that at the point of us developing a new hospital in York and using all the tools at our disposal to predict future use, nobody,
Talk about the
unfortunately,
pandemic.
could see a pandemic coming,
No,
and the changes that's had to give us. So no, that's absolutely true.
absolutely.
We have presented a COVID forecast to the York Health and Wellbeing Board in relation to mental health needs, and obviously Peter Roderick, who I know is in the room as well, has been looking at the impact on local population health. So we are looking to see and reviewing our patterns of patient flow against that to see if it's where we would expect it to be or anything unusual. However, our activity and our intention within the trust is always to place people and provide an inpatient stay in their nearest ward, and that remains a goal for us.
I think it's also fair to say, Chair, that Foss Park's design, single ensuite rooms, has allowed us to keep people in York if we can during the pandemic. It's much easier to manage the sort of COVID strategies within a new, clean, crisp environment with single rooms than it would ever have been in any of our previous inpatient environments. So it's helped. It hasn't solved the whole problem, but it's certainly helped.
Yeah, thank you very much. Councillor Heaton, please.
Thank you. Over recent weeks and months, I've had occasion to speak to people who are in leadership positions in operations within mental health. And the thing that they keep saying is that on any improvement journey, the easiest thing is to put plans into operation. And obviously we've put plans into operation here. What they say is the hardest thing is to make sure those things are embedded throughout the entire organisation. Now, obviously, there's reference to training there. I was just wondering if you could give us a bit more detail there on what the progress is in making sure these improvements are embedded, and obviously to go from requires improvement to good, and then what specific plans there are to keep this momentum going forward, please.
Okay, thank you. A central tenet of the strategy is our assurance and oversight that's been introduced, and the quality assurance schedule that was introduced in April. So obviously the people that you've spoken to, I would absolutely agree with that it is easy to do things for a week or a month, but it's much more difficult to sustain it in the longer term. And we also need to give the right support to staff to sustain it and embed it in their practice on a daily basis. So the strategy to help us embed that is the practice development teams that have been put in place on inpatient wards, the additional training, and then also the quality assurance schedule. So the quality assurance schedule does not have an end date. That will be run consistently to make sure that we are still embracing good quality care and practice on all of our wards. That also enables us to work with the staff that if standards haven't been met, to identify what the root cause of that might be and to be able to go in and offer any additional support that's needed. So they are key strategies. In terms of how we go from requires improvement to good, and I would hope to outstanding, that surely has to be an admission and aspiration, for all of us. We have a new journey to change. So we have a new chief executive in post, and we've got a new strategic framework that's been implemented across the trust, which is our journey to change. There are 3 clear strategic goals that sit within that framework, and now we need to enact that and identify how we will achieve those. And that's all in process at the moment within the trust.
Thank you. And what's the sort of timescales on that strategic framework, would you say, at this point?
Yeah, so the strategic framework is a 5-year framework. However, that doesn't mean we only want to achieve the goal at the end of the 5-year period. We have plans in place. So for the CQC, the actions that have been identified so far, we have a roadmap within the organisation. So for example, the introduction of the safety summary safety plans was for inpatient services. However, we've applied the same methodology to all of our community services. We've implemented a timeline where all patients, 100% of patients, whether in inpatient or community, will be supported with the new safety summary safety plan approach by the end of March 2022. And an update I provided this morning internally is that across North Yorkshire and York, we are achieving that at 85% and 76% respectively. So we are absolutely on target to achieve what we've set out to achieve so far. From there, we'll be looking at other actions that need to take place. Some of it's about process and some of it's about quality, and making sure that we don't stop learning lessons from any incidents or complaints that we receive into the trust. And they're now being truly embedded.
Thank you very much.
Councillor Bassey next, please.
Thank you, Chair. I was particularly interested in the paragraph that dealt with an Oxyhealth digital care assistant. And I was hoping that you might give us a bit of a clearer understanding of what's happening here, because I read sensory monitoring of patients and users presentation, and I'd just like to understand a bit more how you're balancing monitoring of patients in their rooms with privacy. And secondly, related to that, given that you've said you're expecting a number of new patients presenting as a result of the pandemic who've not previously presented in this kind of an environment, whether this kind of monitoring presents special challenges for people who've never previously been in such a context.
Okay, thank you. I don't know if Tolu, you want to come in on the Oxyhealth question?
Yeah, sure.
Thank you.
The Oxyhealth is a monitoring system which allows the clinical team to be able to kind of monitor things like blood pressure, pulse, but also to be able to note when there's a change in posture or position. And that's particularly relevant if somebody falls, somebody's trying to get out of bed. It becomes really relevant. It also notes if there is a significant period when there is no movement at all, which becomes again quite crucial when if you have individuals who are particularly who have difficulties and are in the course of trying to self-harm. It picks up things like that, allowing staff to actually respond more quickly. Now, what it doesn't do is staff cannot effectively see the patient on the system. What they see are almost like digital hot areas or cold areas that gives them a sense of change in posture, change in position. So that addresses some of the concerns around privacy. The other thing that is done is the patients are made aware of what the system is, what the system does, how the system works. So they are fully aware of what the objective is, which is really to ensure, one, their well-being and their safety, but also to reduce the amount of disruption to patient care. Because one of the feedback we've had historically is that when staff go in to actually check a patient's respiratory rate or blood pressure, or to check that they're actually breathing, you've got to go into their room, you've got to open the door, you've got to put on the light sometimes, and all of that causes disruption to patients who may well be sleeping at the time. And all of this helps to address some of those issues as well.
If I could sorry.
Go ahead, Martin.
I was just going to say, for added reassurance, and Tolu, that's the best descriptor of Oxyhealth I've heard, and absolutely great. What I would say as a nurse is this does not replace nursing. This is aiding the nursing process. So the privacy bit, Tolu, absolutely right. It will reduce some of those interruptions, and those what people often see are invasive. I'm coming into your room at 2 o'clock in the morning because I've got to do your blood pressure, whatever. But what it doesn't do is it doesn't replace nursing. It doesn't get us to any scheme where we reduce staff members or we over rely on technology. It is literally an aid to help us.
Absolutely.
Yeah.
Thank you.
Thank you.
Thank you. Further questions, members? I have a question on bullet point 7 on page 17. Well, it's bullet point 3 in the what people who use the service say paragraph. It says there patients commented they sometimes found it difficult to cope on the ward as the wards were very busy and some patients were acutely mentally unwell. I mean, it sounds, bearing in mind it's a newly built and modelled mental health facility, it sounds a little bit concerning, as the ward you would expect would be a place of safety and sanctuary. Can you tell us a little bit more about this, whether this is a regular occurrence and what possibly might be happening for that to have been suggested?
So let me try and give a start to that. One of the challenges here is the fact that every patient has their own individual room, we cannot insist that people stay in their rooms. So there are times when you have people kind of coming together in a particular area, and particularly there are occasions when we have people who are particularly significantly unwell. And so their orientation, their awareness at that particular point in time is not usually optimal. And so you do have times when you might have a group of people coming together at a particular point in time, which might be the point where things are quite noisy and things are quite loud. Whilst that might not necessarily be something that someone who has a psychotic illness is most concerned about, that would be something that somebody who has a depressive illness might feel very concerned about at the time. And that's where you get some of those differing feedback and differing views. And that's sometimes difficult to manage. What we tend to do is using the nursing staff on the ward to actually try and work with those individuals, because again, we've got to be careful about ensuring that we're not segregating people, but it's also about meeting the needs of different people by balancing needs. So we're constantly in that work of balancing the needs of people. I don't know if you have anything else to add, Martin or Naomi.
I totally agree with that, Solly, and I think, Chair, you're right to pull up that sort of line in the report. I think there are two things for me. One is, it is positive that people are able to give us that feedback and for us to learn from that and think about that and remind our nursing staff, who are very familiar with very stressful, often very challenging situations, that a rise in the noise temperature means, are we looking after everybody? Is everybody okay? Is everybody all right with this? So-and-so's just come in, they're very quiet, we need to keep an eye, those sorts of things. So it's absolutely right that we get that sort of feedback. Our nursing teams, and I can say this having reviewed some of our practices at Foss Park, having to review things like CCTV and things like that, our nurses are extremely professional in managing those situations. But if you are a new patient on the ward and you've never been on an inpatient ward, they can be quite formidable environments, and our skill and our task is to make sure that people feel as comfortable and as safe as they can, and that we protect their dignity as far as we can. But it is a challenging environment sometimes, and I think Tolly is absolutely right. Some conditions struggle with the observation of other conditions. If you are numbed a little by your depression, your motor abilities are slow, you are sitting and observing, and somebody else is quite elated, for example, using bad language maybe as part of their condition, it can be quite difficult. And our job is to make sure that for all those people on that ward at any given time, we're taking care of all their needs. So I think you're right to pull it out. I think some of it is life on an inpatient ward is very challenging sometimes. And that is the job that we must do. It's what we are setting out to do.
Thanks, Martin. The final comment I'd like to make in relation to the wards and the environment, Chair, is that with Foss Park opening during the pandemic, some of the works we had planned on those wards has been halted and postponed. So, for example, on Ward View, which looks after older patients with organic needs, we have been unable to decorate and to use all of the spaces to their full effect since the opening of the hospital. So we do have lounges, we have other spaces that are available. However, we're still progressing those and making sure that they're an environment that attracts people to go into them and use them. And we know that when people have positive activity and they feel engaged, that can also help reduce, the overall temperature on the ward.
Thank you very much to each of you for for adding your comments there. And I'd just like to say on behalf of the committee that we're grateful for Naomi having actually approached us rather than us having to ask you to come to us when you had the CQC inspection. I think that's refreshing, and that's certainly a positive movement from what we've possibly experienced in the past. So I hope that close cooperation and between the partners in the city continues, and I certainly welcome that. And thank you very much for coming as well, speaking to the briefing this evening. Thank you.
Thank you, Chair.
Thank you, Chair.
Thank you, Chair.
Thank you. So we'll move on to the next agenda item, item 5, which is the report of the Chair of the Health and Wellbeing Board. Councillor Runciman's here. And Peter's possibly help answer some questions as well, potentially. Do you want to give a brief introduction, Carol? Obviously, members will have read the report, I'm sure, but thank you.
Chair, can I just make some brief remarks to start with? Yeah. The most important bit of this report is, of course, the bit on page 31, which is next steps. All councillors will have heard my report or read my report in full council, and this comes hot on its heels. So you will know that I and everyone in health and adult social care have been extremely busy, as has the Health and Wellbeing Board. But there are just a few things that I just want to highlight. One is the forthcoming change from the CCG to the ICS and the ICB and the ICP and all the other little acronyms that the health service enjoys using. And it's absolutely essential that the Health and Wellbeing Board is right in that picture, because they have to report to the Health and Wellbeing Board. So I need to be on board with what's happening. And that relationship, as it says in one of the bullet points in next steps, must be a very close one. I also want to mention, if you read the partnership reports, which I'm sure you will have done, you will have realized that there is a gap, and the gap is children. And there's quite a lot of work going on now to create a replacement for the You're OK board, which I was in on right from the beginning. And unfortunately, I think partly because of COVID, it's faded away. But the Health and Wellbeing Board is very anxious to make sure not only that the first 1,001 days of a child's life are as healthy as they can be, and the child has as much well-being as can be, but also children above that age, up to 18, unless they have special needs, when it's up to 25. So that change is coming about, and I'm very pleased it is a priority for me. The other thing that you might need explained is about the Henry programme. And I'll do that, although I'm sure Peter could too. The Henry programme is working with very young children to look at weight sensitively. I'm saying this because the weight you are when you're young tends to influence the weight you are as you get older. And we do know that at Key Stage 1, when the child measurement programme was in action, I don't know if it started again. Has it started again? No, Peter didn't know. It's due to start again, I know. There is a change between Key Stage 1 and Key Stage 2 when children tend to get heavier. The reason the Henry report is coming to you in January is because we're waiting for training places. The people, there will be at least 3 of them who will work on the Henry programme, and it stands for something that at this moment I can't remember, but never mind, it's about children's weight. They have to be trained, and there aren't vacancies on that course at the moment. And we hope that they'll be trained by January. So I hope that at some point, Scrutiny will look at the Henry programme when it gets started. I'll be very interested to hear what you think of what's happening. because it is a particular problem. And we're not quite sure why children get heavier between Key Stage 1 and Key Stage 2, because I know from my time working with the schools that the schools and the school meal service are very careful about what they give children. They don't give them chips every day, although some of the young people would really like it if they did. So something is happening somewhere. I have a feeling it might be a little bit about children making their own choice of food when they're not in school, but that's only me guessing. So yes, please, will you call for that report in January 22, and I should be very interested to see it when it comes. And now I'm very happy to take questions, and I'm sure Peter is too. Peter, do you want to make any comments?
Well, just so Henry is health, exercise, nutrition in the really young, I think is the acronym. Councillor Runson was absolutely right. Targeted very much at that very young age, but a whole family approach where the family are given really quite a lot of sort of help to program a good diet in, and we know that the dietary habits that are formed in the first sort of 5 years really do then lead to both the body's sort of growth and what the body expects to get from a sort of a dietary palate, but then habits later on in life. So the Henry programme, as you were saying, Councillor Runciman, is starting very soon. In terms of the National Child Measurement Programme, NCMP, the COVID sort of lockdown happened in the middle of the year. So we have a half a year's worth of data, and then the most recent year they chose a small sample of schools because they appreciated with COVID measures in schools it was difficult to run, which I think is 4 schools in York. So it's not the same. You're absolutely right as previous years when it's always been nearly every child is weighed and measured. That's not the case over the last couple of years, and we'll have to wait for national guidance in terms of the year after what they propose for us to do.
Thank you, Chair. Yes, I just want to pick up on the issues of obesity and weight problems that you've mentioned there for children. And in the report, of course, it talks about physical activity and health issues for adults as well. I'm aware that the council has recently launched an app called Better Points. And I'm just wanting to have some understanding of the degree to which this area is engaging with that area of sustainable transport, sustainable travel, incentivizing people by giving rewards. I understand the whole idea of this started in the town in Finland, and we've copied that initiative. I'd just like to get a sense of how you think that we might use that in the years ahead to help both children and adults manage weight issues and just health generally.
I'll start, and then I'm sure Peter will add something. I think it's a very challenging one. I think every councillor that has got a school in their ward knows that the place parents want to park, if they have to come by car, is right at the school door. And also some of them come by car when one might think they might wish to walk. So there's a bit of a battle, that one. But I do think that services are working together. The Healthy Child Service, healthy weight is very important to them. The active travel, that's another aspect, and they do all work together. But of course, that's what we were just saying with Henry. The habits that are built in when the child is young will go on being built in. And it's not until the child gets to secondary school, really, where they start traveling on their own volition. And there's somebody who I remember vividly, I cycled 3 or 4 miles to school every day without a thought. And at my primary school, I walked with a friend. Now, I'm not sure that parents these days would let a primary school child walk as far as I did with a friend. The world has changed. So it is a very difficult one, but I do think that the services are working together. And I think when Henry comes on board, I hope they will do so to greater effect. Peter?
Yeah, and just to add to that, I mean, I think one thing in public health that we've wanted to create a culture of since we've joined the council in 2013 is a sort of health in all policies approach, where public health is a small team within the council. It won't drive every health initiative, and neither should it. Health should be hardwired into what we do. So it's been great to see active transport travel colleagues join the Healthy Way steering group, which my consultant colleague Fiona chairs, and join those things up, and apps like you describe, Councillor Vesey, which have that potential to lead to health gains, but environmental gains. You know, they probably help in a number of different ways that we want to improve the lives of the people who live in York. So we do actively engage on that. And a couple of years ago, the council also signed the local government declaration on healthy weight, which was really all about what can we do as a city to make exercise easier and make a healthy diet easier, bearing in mind that most of the determinants of those things could be easy to lay at the door of personal choice, but we know it's the conditions that create the personal choices, probably because we know they're correlated with people who generally have less social capital, and we know that the wider determinants of obesity or wider determinants of a sedentary lifestyle are generally determined by the socio-economic structures you grow up in, and often the commercial determinants of health, because often many people make a lot of money from high fat, salt and sugar products, and those are very much part of what that declaration was aimed at. It's trying to reduce advertising, for instance, reduce the targeting of children and young people with sponsorship and commercial sort of opportunities. So there's definitely a lot of join up on those agendas.
Thank you. Any other questions, members? Councillor Taylor.
Thank you, Chair, and thank you, Councillor Runciman, for bringing this report here. I do have a respect for you. You own your portfolio proactively. I'd never accuse you of hiding away. I've got a few questions, but I'll just do two for now, Chair, if that's all right, and see how things go. I'm asking you this question based on a sentence in priority 1 for the Health and Wellbeing Board. So these were the ones agreed, I think, in March 2020, page 25. It's just the sentence that says the Health and Wellbeing Board should drive the strategic direction for the health and social care system at place level. And you read that and you think, yeah, it should. And I expect you to say it does. But what I'm trying to sort of get a sense of from you is, do you think we do that to our maximum as a city? And to use quite crude language, and it's not to trip you up, but if there's two sides of the spectrum, one is it's simply a talking shop where you get lots of presentations that are very interesting about things that our partners want to do or are doing, and the other side is they're really listening to us and they respect what we're saying. Where do you think we sit on there, and how do you think we can improve on where we're currently at?
That's a very interesting question. It almost sounds like politics, with a small p, not a large p.
Yeah, small p, definitely.
It is a difficult one, because the pandemic highlighted it. We were putting services into the community, and you've heard Naomi and Brent saying they were putting services in the community. And the hospital was taking people in, and they wanted to get people out into the community, which put extra pressure on what we were doing. So sometimes our priority of putting services into the community is pressurized by other people's priorities in, say, getting people out of hospital. The priorities aren't all the same all the time, is what I'm saying. They change with circumstances. I think that the Health and Wellbeing Board does influence the priorities in other services. And I've said this to this board before. One of the exemplars of that was suicide prevention. That first came up at the Health and Wellbeing Board and now has filtered down through the system and is there throughout the system as a priority for everyone, including the police, which I'm really pleased about. And I think mental health is the other one. Mental health in the community, not just mental health in inpatient care has become a big priority, I think, for everyone, highlighted by the pandemic. The challenge I see is not just the one you've described, it's the relationship with the ICS. And if the ICS feels it's prioritising something that the Health and Wellbeing Board has not prioritised, how do we resolve that tension? And we haven't got to the end of that discussion yet, but it's a discussion I'm quite determined to have at some point. Peter.
Well, just to come in on that last point, I would absolutely agree that we are in a point of uncertainty in terms of the changes to NHS commissioning, but with a big overlap with council services and council commissioning, with probably some good opportunities to do things in different ways. But the integrated care system is not yet a body, but the body it will replace, the CCG locally, ceases to be a body in April. And actually it is a year of transition. And I do think it is really positive that the Health and Wellbeing Board has a place in the governance structure of the ICS, a place at what's called the ICP, the Integrated Care Partnership. I think using that place to make the case for the health of the citizens of York is probably a challenge for all of us in that sense, to make sure that we get the best out of this new arrangement. And I can definitely assure board members that there's a lot of work going on to both understand the new structures, first of all, and then to make sure our voice is heard in them.
Can I just check, Councillor Vassie, was that related to this? Yeah.
Fair enough.
Thank you, Chair. Yes, it's at our last meeting, we heard that the forthcoming changes that will be made may require us to have a clearer strategy with clearer targets going forwards, and that up until now, the aspirational content of our strategy has worked well, but that in the new situation we may find ourselves next year, it might be helpful to strengthen our hand by having clearer ideas in our strategic documents about the kind of things we want to see, the outcomes we want. It's just good to get a sense from you whether you support that and where you think the areas are where we might need that kind of reinforcement to help York fight its corner.
Yeah, it's a very interesting question. I was reading the data report that came through to me this morning. It's an interesting question because it depends which side you look at it from. You've got clear KPIs, obesity, reducing obesity being one of them, so that's why the Henry programme is important. But if you look at something like safeguarding, the KPIs tell me that there are more safeguarding referrals, and that is bad. In my book, more safeguarding referrals is good. It's what happens after that that's important, not the fact that people are just reporting them. We want people to report safeguarding issues. So I think it should all be measured very carefully if it can be measured. And the other hitch is that sometimes it's difficult to measure what hasn't happened. And this is the issue that comes with the local area coordinators. They are reducing the number of people, say, going to a surgery or going into serious mental health problems. But it's very difficult to measure. You don't know what would have happened if there hadn't been that early intervention. And that's a really hard one. I find that one very, very difficult. Peter, would you like to respond?
Well, I'd say on the strategy front, interestingly, the integrated care system takes a very similar approach to our York Health and Wellbeing strategy. May even say that we were there before them in that sense of taking the similar headings. Our health and wellbeing strategy runs up until the end of 2022. So I do think and totally agree that making sure that as we look to replace that one with a new one for the city, one of the audiences of that, not the only audience, but one of the audiences is the integrated care system, who will look at it and say, what are the needs of York as a place? What's York's specific population need, successes and assets, and how do we make sure that that presents the best front to the integrated care system so that we get the right resources to match our needs and assets. So absolutely, I'd agree that it's important to get that right, and that's something we're actively talking about at the moment and the board will be discussing.
Councillor Taylor.
Thanks, Chair. We sort of got on to almost answering what my second question was going to be, which was looking forward. And, you know, we're sort of, the Health and Wellbeing Board is swimming around there with all the different other boards and initiatives and changes that are on the way. And again, this is not to try and trip anybody up. It's an honest question looking forward about, I'm wondering basically, is there an anxiety in the local authority that if we don't get it right in terms of placing ourselves correctly within the changes that are coming, that the Health and Wellbeing Board might not become redundant, but lose influence?
I think that's a really interesting question, Callum. Thank you. I've been on several calls in the lockdown with other Health and Wellbeing Board chairs, and that's what I hear them say. That's exactly what I hear them say. They are afraid that the local authority, actually, not just the Health and Wellbeing Board, the local authority will lose influence. And I think we can only maintain our influence by being a clear voice for the local authority at the table of the ICS. And of course, there's a limited number of people from the local authority go to the preparatory meetings to the ICS, which don't exist because the legislation hasn't gone through, has it, Peter? So it's a difficult one, but we've got to keep at the table and we've got to keep making our voices heard. Otherwise, I think that is a possibility. And my anxiety would be that everything is swallowed up into the ICS and is centralised.
Thank you. Appreciate your honesty. It's interesting.
Is that a supplementary, Councillor Heaton? Yeah.
Thanks. More a point than a question, I suppose, but just in terms of looking at local authorities and people looking at losing influence, that's something that also is measured with, is there with trusts as well. Yeah, particularly where you've got organisations where there's a large trust and everyone's coming in together, and you know it's something, particularly the way the ICS development is going at the moment and is still somewhat amorphous, is troubling a lot of people, and obviously things are starting to develop, but we're quite close to April and we've still got a lot of questions hanging over it.
Not a lot I can say to that, David, because you're right. We are very close to April and the legislation hasn't gone through yet. And another worry, I suppose, for me is I'm well aware that legislation can change at the last moment, and then we won't know what we're facing. So we can only keep a very careful eye on it, and as I say, make sure our voices are heard.
Well, yeah, just to add that I think people should be sort of anticipating that the first year that the ICS is in place, a lot of things will still be in transition, and compared to 2013 when there was a set model, albeit a contested model that went through several debates, but there was a model that was proposed and then got into legislation within quite a bit of time, not a huge amount of time, but a bit of time to implement. The approach has been a lot more flexible this time around with the national legislation. ICSs are the fixed point in each area, but underneath them, there is a lot of flexibility. In one way, that's good because we can define what we need locally. In another way, that means there's uncertainty, and certainly when it comes to issues like finance and contracts and shared assets liabilities, the close down of CCGs into the ICS next year, there will be, I imagine, a lot of shadow arrangements for a period of time with set dates for becoming formal, and that's probably necessary because it the due diligence on doing that transition needs to be very careful. And the CCG at the moment, I'm speaking now, I guess, in my CCG role, many of our conversations are about due diligence and close down, making sure that our staff are well cared for and that their future under a staffing guarantee, which means that they're not sort of that there isn't any likely to be any job losses, but there is a sense of which the staff well-being in an uncertain year is needing to be really well handled, and there is a sense as well in which the CCG as an organisation needs to make sure that all of its risks and assets are well transferred to the ICS. That is going to take quite a good period of time. I think the good thing is we're all going into that one central organisation of the integrated care system, and because of that, we'll be in that one place to make sure that that is well managed.
Councillor Taylor.
Thanks, Chair. It's not a supplementary, it's a different question, if that's all right.
Right.
Thank you. Councillor Runciman, I think it was in response to Councillor Vassey's question, you touched on how it's hard to measure the things that aren't happening as a result of interventions. And as part of that answer, you mentioned the work of local area coordinators. And it got me wondering, in the current climate, when local authority finances are bleak, to put it as positively as I can, where do we start with roles like that moving forward when it's going to come down to statutory versus non-statutory and things we need to have versus things that are nice to have? I sound like I'm in a different political party there, but there's real tough choices there. And if we can't currently measure the benefits of roles like local area coordinators, are we trying to find a way of better doing that? Because that type of role is highly qualitative, isn't it? Based on individual experiences, and that's not to disregard it, but when push comes to shove, that's a real challenge. And if they are doing good work, we need to find a way of measuring that so that we can make a defence for them.
Yeah, that's absolutely right. The first group of local area coordinators, an evaluation was done by the University of York, and it looked at their role in early intervention and did a lot of listening to people that had been supported by local area coordinators and didn't look at, if you like, the financial benefits that it brings, because early intervention, of course, stops things getting worse. And in fact, I had a very brief conversation with Jamila about this a little while ago. The second lot of local area coordinators, which are in place now, the evaluation is being done, and I'm really sorry, I can't remember whether it's Oxford or Cambridge University, but one of them is doing an evaluation and it is trying to evaluate the financial benefits. The difficulty with that, and I think I've said this before, is that it may not save money for the council. It will save money for, say, older people going into care, but it also saves money for the hospital, say, or for TUV at Foss Park, say, but they are doing that work, not quite as we speak, but they are doing that work at the present time. And that is, Chair, that might be something you want to look at when that evaluation is done of local area coordination. It might be something to bring to this scrutiny committee to have a look at, because I think they'd be very interested. I can't tell you what the outcome will be, but I can tell you that I'm a firm believer in early intervention, and that is exactly what they're doing.
Thank you for the answer. I think it's really interesting and a bit daunting, really. I think we're going to hear a lot more of scenarios where we have to not necessarily do what's best for the council, but what's best for people who might use different types of services. And that will take brave officers and brave politicians, I think, across all colours. Cheers.
Thank you. Any further questions, members? Councillor Vassey.
Thank you, Chair. Yes, just a quick one. I think going on from what Councillor Taylor said and how we're listening and who we're listening to, I was reading with interest a bit about the Health Watch reports and where they come from. And obviously they're a snapshot in time. And we're in a rapidly changing situation. And it just rang a little alarm bell in me. On one hand, I was very pleased to see, for example, that there was a report on listening to BAME people about health and social care services in York in January. But then equally, I think to myself, well, you know, we're now 10 months further on. What monitoring goes on from these various organisations through the year, and how often are they reporting to the council, so that we can have confidence that in a rapidly changing world, we're not losing a grip of things?
Yeah, that's an important question. Health Watch reports, I was always a bit worried about them initially because I felt that they disappeared into thin air. And they are really very, very good because they're actually talking to the users of the service. We now have a subgroup, I think we call it, that actually receives those reports and looks at them and monitors the recommendations to make sure that they are being carried out. I don't know if Peter knows any more than that. It isn't a group I go to, but obviously those reports will come back to the Health and Wellbeing Board.
It's not something I'm directly involved in, but absolutely Health Watch have that role in the system, don't they, of making sure the public, the patient voice comes into the Health and Wellbeing Board. And I do know that, as Councillor Monson was saying, that the reports are very high quality, and not only that, but they have an active sort of listening service, as it were, that, you know, it's very easy to make a comment about health and care services through to Health Watch in an anonymous way, where they capture it quite systematically, and it does feed into, for instance, if they get quite a lot of people talking about a certain issue, that will drive the topics that they are choosing. So I think whilst any report goes out of date the moment it lands in that sense, I think there is definitely, if things keep on cropping up, they will keep on getting Health Watch attention, which I think is really helpful.
Well, we've historically had quite a good relationship with Health Watch. There's been a bit of duplication, I think, in the past, which is why I think a lot of it comes through the Health and Wellbeing Board now, rather than us as well. But certainly the manager of Health Watch in York does drop us a line from time to time with areas of concern that she might have. And obviously dentistry was one of them, and which is why we've invited them along in January for the meeting.
And Chair, would you use the Health Watch reports to inform some of our commissioning, especially if there's trends within them, so with the learning disabilities and mental health? Would you then use those reports to look at how we commission differently? And as Councillor Untitled said about prevention, a lot that's in Health Watch reports is around prevention.
Thank you. Any further questions, members? No. Which obviously we've spoken a little bit about the ICS this evening already, or the changes that are going to happen. Sharon Stoltz has been in touch, and I was going to mention it at the work plan section, but probably a relevant point to make now that we are going to have it as an agenda item. So looking at the governance arrangements. And the suggestion from Sharon was that we have it at our April meeting, which is the kind of the end of April, because by that point it will have gone live, and we'll be able to invite people from the contacts within that to get some early indications of how or what the changes might be. Right, thanks very much, Councillor Runciman. You're welcome to stay, or if you need to depart, yeah, it's entirely your choice. All right, okay. I don't know how members feel, whether they want a quick comfort break or whether you want to go straight into the final item. I'll take a steer really from. Yeah, should we have 5 minutes? What time is it now? Just before 7. Everyone's back. Is that okay? Okay, thanks very much. Agenda item 6, do apologise, turn the sound on. 2021-22 Finance and Performance First Quarter Report, pages 33 to 46 in the agenda item. And I'd like to welcome Steve Tate, the Head of Finance for Adult Social Care, and Terry Rudden, Strategic Support Manager. Good evening, gentlemen. Would you like to give a brief introduction to the report, please?
Yeah, hi committee members, my name's Steve Tate, Acting Finance Manager for Adult Social Care primarily. Hope you've had a chance to read the report. As you can see, Adult Social Care is forecasting a £1.7 million overspend at the first quarter. What is probably quite significant is we need to deliver a further £1.3 million worth of savings between the time this report was originally put together and the end of the financial year. The majority of those savings are about securing cheaper market placements, reducing the volume of home care that we purchase, and also increasing our continuing healthcare income. One positive thing I'd like to mention that's happened since this report was written, paragraph 11 talks about the hospital discharge programme ending October. That will now continue to the end of the financial year and will help the financial position. On the public health finance, as you'll see, they're underspending generally due to vacancies by 224,000. That gets put back into reserves. And those reserves are committed against spend over the next 3 to 4 years. The Q2 report is going to executive on the 18th of November, and the papers will be published next week. Pass you off to Terry.
Thank you, Steve. Committee members. The performance element of the report follows on naturally from the financial position in that it does reflect an increased demand for services for adult social care. You can read the report, and I'm happy to take any questions you've got on it.
Okay, thank you. Members' questions, please. Councillor Taylor.
Thank you, Chair. Thank you for the report. I mean, it's sort of been very briefly covered in the opening remarks, really, that there's overspent and there's increased demands. And I'm wondering if you might be able to share, you know, in advance of budget season, where you think the next set of tough decisions might need to be made. Because things aren't going to get any easier, are they?
So, because the position isn't great in the People Directorate, there are working groups working across finance and performance that meets fortnightly to start looking at some of these areas. Jamila Hussain is reorganising how we monitor the budget, the governance around that. And there are some areas that we discussed on Monday morning with the Chief Financial Officer and the Chief Operating Officer. So it will be looking at things like what a statutory minimum might be. It'll be looking at the delegated authority of officers to ensure that people are authorised at an appropriate level. We'll be revisiting the savings that we've already got in and the plans we have to deliver those savings. How we can work with the community and voluntary sector in terms of them supporting us. Whether we're making the best use of our internal services and whether we are the best people to run those services. They're the sort of decisions that are being talked about now as the budget proposals are going through. So they're the kind of areas, and there is several working groups looking at it particularly. Is there anything else you wanted me to add?
No, that'll do for now. Cheers.
Thank you. Just before, it's supplementary really to that, so before I go to Councillor Hook. Given you're saying that the council will have to cover 596,000 of costs relating to unachievable savings, how confident do you feel that you'll make the 1.3 million predicted savings?
I think some of it will be tricky. I think continuing healthcare stuff is tricky. We know that health are financially challenged, the CCG. We know that the market is a difficult place to operate in at the minute, and we're certainly not alone in that. So before this meeting, I was on a regional finance managers meeting across the board. There's difficulty securing nursing and residential care at what we would call our standard rate. Most providers are bumping it up at the minute for obvious reasons, for, you know, to be able to attract staff. to be able to implement the infection control measure they need to do. So it is a very tricky situation at the minute. And so hence the need to sort of put in these extra measures and sort of governance arrangements to sort of drive through and keep the budget at the very top of the adult social care agenda for the next 6 months to a year.
Okay, thank you. Councillor.
Thank you. I just wondered whether you think that new people who will need help perhaps because they're not getting the medical care that they need and they're becoming increasingly infirm, the people who have aged significantly just over the last 2 years because of isolation and other matters, whether they might slip through the net because of all the limited funding and the need to make savings, and they might get overlooked because they're not already in the system, as it were?
The experience that we're getting told by social workers that there are the type of people coming to our door, people we haven't seen before, people who've been isolated or have not had access to services for the last 18 months. So I would say they're probably more the cause of the financial overspend rather than us missing them. Obviously, we have people like local area coordinators. We touched on that earlier today. They are a conduit for getting those people through to services, maybe help themselves where they can. But if not, that's a sort of a door that is being used to refer people into adult social care.
If I can just add to that as well, I mean, the front bit of the table, the first paragraph in the performance section of the report is around the number of contacts that our community team are getting, and it's gone up by 17% compared to a year ago. So it is the case that those people are contacting us and they are getting assessed.
Councillor Vassey.
Thank you, Chair. Yes, I mean, I suspect we all feel the same frustration at the pressures that are bearing on society and the funding that's available, whatever. And I'm just finding myself trying to find glimpses of light here somewhere. So are there opportunities, do you think, in the years ahead that may accrue from devolution in terms of providing joint procurement opportunities that we don't currently doing anything with?
Potentially, that is certainly one of the work streams we're looking at in terms of improving the situation, sort of a joint brokerage approach to some of our services. We had a demonstration of a system. There's something regionally that's been looked at called PAMS. A module of that is around brokerage, which is something that might give us opportunity to cheaper placements. The other side of that, though, is those placements might not be in York. We might have to start placing people wider in the region where appropriate. So that's probably where the opportunities are going to come around joint brokerage.
Thank you. I mean, I can see that that will cause problems of its own, but I'm glad to hear that we're wrestling with such opportunities as may exist. And the other thing that occurred to me, because we're often hearing about staff difficulty of recruitment and all of that, are there things that, in your view, we could be doing to grow the pool of trained staff that might be available? Are there interdirectorial things that need to be happening in this city in order to try and widen that pool of people we have access to?
So that there are various recruitment campaigns going on. We have identified a small pot of money to increase the social care workforce, particularly at this time. And I know they were looking at some innovative ways of doing that. I can't speak from an HR perspective, but I could certainly find out and circulate what they are doing differently rather than just sticking it on the normal websites and things like that. So they are looking to do things differently. We have also taken in Rickle. So Rickle, we're an external home care provider, and we internalise that service. So there may be opportunities for us to grow our own work staff to deal with some of the issues as well. And it's not, I think it's not even a regional thing, it's a national issue, getting the workforce into home care. And you probably won't have had a chance to read the sort of budget papers that came out on Wednesday, but there is significant money supposedly new money in that settlement around the workforce in social care particularly is about 500 million off the top of my head. I think they were looking to set aside for it.
Yes, and to give my thoughts, Chair, it seems to me that relatively small local authorities often fall into the trap of not having a set of projects sitting on the wall behind people's desks, ready for those moments when the government suddenly says, oh, here's 300 million quid, who's ready with something? And I worry that we're always playing catch up because we've not got those projects sitting there waiting to be able to say, well, we've got a plan. If you give us 2 million quid, we will train 40 people or whatever it is in order to try and help ourselves. And in these situations, we can become very despondent and sometimes lose the proactive part that we might play, which is why I'm asking those questions.
May I respond to that? So we acknowledge the budget is a problem in terms of finding the amount of savings we need. So as part of that will be a series of service reviews where we are looking at some of those bigger items where we can move quite quickly and do things very differently in order to help the budget position. Other things that are going on to sort of ease your mind a little bit is we are looking at intermediate care and that whole discharge to assess pathway. There's a company called Then that are being funded through the Better Care Fund that are going to do that. So maybe they aren't ready off the peg to go like that, Councillor Vassy, but there are some things happening that we're looking at to improve the situation. And the strategic service reviews are certainly one of the key areas, I think, in terms of us setting a sustainable budget for the foreseeable future.
Thank you.
And can I just come back
yes,
on
of course,
that just
Camilla, yes.
slightly? And some of the schemes that we do, so we do have schemes on the shelf ready. However, some of them are about growing what we've got and what works at the moment. So rapid response, prevention through the voluntary sector. And sometimes it's about getting the workforce in time to grow what we've got that's working already, in time for those fundings to come in. So I think it's a bit of both. It's about what new schemes can we do, but what are those areas what we can grow quite quickly that will prevent the additional spend Steve's talking about, so that long-term high-end crisis spend to that short-term preventative spend. So when the money comes through, well, hopefully we will be really prepared for using some of that in the way we want to.
Can I just respond to that, Chair? It would be good to get a sense of whether officers thought that there was a constructive part that scrutiny could play to encourage those developments of ideas, those to help us be ready for those moments. I'd just be quite keen to hear whether there was something that officers thought scrutiny might do to help.
We are working with our finance colleagues now to prepare a performance report with Terry, a performance report that looks quite clearly at what activity is happening, what services are being used, and then the finance that wraps around that, plus all the schemes that we commission through the BCF, the Better Care Fund, as well as the schemes we fund through commissioning. And I think maybe that report, once it's completed, because we're updating and it's new, Councillor Runciman can bring to the committee here to then to be scrutinised about those 2 or 3 top schemes we would want to enhance and grow. And that could be a place where we could have a look here at scrutiny of what are those schemes we should be looking at growing, and what are those schemes we should say, yes, they're working well, but we shouldn't commission any more of that, and that would be helpful. I think the other area, what Steve slightly alluded to, is commissioning care wider than the York footprint and supporting a wider range of providers that might not be in York, and individuals might not actually have their care delivered in York, but wider, and discussing that in this committee and how we can support that going forward.
Thank you, Jamila. Councillor Taylor.
Thank you, Chair. One thing that caught my eye was section 10, or paragraph 10 in the report, which looks at the projected overspend of 289k on the community team. And within the reasons sort of raised for that are vacant posts in the team being covered by Work with York staff. And it's a declared interest of mine that I'm one of the non-exec directors on the Work with York board as part of being a councillor. And I know that they're always hiring to people to work in that type of area. And I always think, without being really, really close to the detail, surely it's cheaper in the long run if we actually have properly funded roles in-house than having to repeatedly keep going out for that temp work. Is that too simplistic, or?
No, and that's definitely something we talked about. So we have a cost control board on a Wednesday where we kind of decide we're better off recruiting on a permanent basis rather than this temporary basis, because the turnover of staff by the time there's a restructure being done in this area as well. We're better off recruiting permanently, even if some of the funding is temporary. So some of these posts are funded through the Better Care Fund, but because the Better Care Fund gets funded, the announcement is annual. We have these people on temporary contracts. So they kind of made a decision, well, we should go out and recruit to them permanently because the risk is small of that funding actually ending. And so that's kind of one of the approaches we took to sort of not using Working with York staff to the same extent. And there is a restructure going in that area, which would hopefully address some of the use of Working with York and agency staff.
Cheers.
Thank you. Any further questions? No. It is a question I ask every year, and I think to some extent the last year or two have been obviously significant challenges with the pandemic, and obviously going forward we'll see increases in things like the national minimum wage, which will obviously have an effect on budgets as well. But at the same time, obviously, as we're coming into a budget setting season, if you like, what kind of reassurance can we have that the budgets that have been proposed to executive are going to be somewhere near sound? Because it seems like every year we significantly exceed the budget in adult social care. It's not just been the last year or two with COVID, but as far as I can remember, every year, I think, in 10 years or so I've been on health scrutiny, I think it's been every year.
We actually underspent last year by 837,000. That was one-off funding primarily from the grants. But I suppose one of the things we tried to put in place is more structure around how the savings will be delivered. So we've got sort of plans on a page supporting this year's saving, which kind of describe how they're going to be implemented, who's going to implement them, how they're going to be monitored. And we do monitor our savings regularly through the year at either the cost control board or an adult management team where they're reported on. So that robustness we are still looking to build in and probably make even more robust this year in terms of the current budget process.
Thank you, Steve. Yes, that's fine. Thanks very much, Councillor Runsby. Are there any final questions, members, in the report? No? Well, thanks very much, gentlemen. So we move to the work plan then. Next month's informal meeting, I think Jamila's going to join us for that. In the discussion on adult social care provision, and specifically talk, I think, about some of the commissioning plans. And obviously we'll have the report on smoking cessation and tobacco control that Sharon's going going to bring to us. As mentioned earlier on, we're going to add into the April meeting the ICS governance arrangements. Is there anything else members want to raise at this point? Related, Councillor Taylor?
Thanks, Chair. I'm sure it will be, but I just wanted to check that item 1 for the December meeting, will we get a sort of written report to accompany that, even though it's informal?
I think it's important that we do.
Yeah.
Yes, yeah.
I don't want to throw work on people if that's come as a surprise. I'm not sure.
No, I think that would be, you know, reasonable to expect that, because, you know, I always find it difficult to ask appropriate questions without having some information to hand. And I'm not very supportive of items when they come forward without anything at all. So you'll follow that up anyway, Louise, won't you?
Oh,
yeah. Thank you.
Cheers.
Councillor Bass.
Thank you, Chair. It's on the dentistry item in January. I look at this list and I know that we talk with representatives of things typically, but I worry when I see we're just having the chair of the local dental committee and a representative from NHS in England, whether we're really going to hear the voices that we need to be hearing here. Should we have, I'm open to people's ideas, but should we have a head teacher to talk to us about dental problems in a school? Should we have dentists, a couple of dentists coming to tell us the practical challenge on the ground? Should we have someone who works in a care home talking about the problems there are within care homes? Whereas I understand it, there are significant numbers of older people who've not seen a dentist for 2 years. You know, could we broaden the people that we're bringing to this? Because I suspect there'll be a lot of interest in this. It's a really important topic for the city and the country. And the more we can ensure that we're hearing a picture and not having it filtered by too many institutional processes, the better I think our discussion will be. It might be trickier, but I think it'll be better.
Well, I mean, we can certainly ask Sharon's advice on that, and Sharon from Health Watch actually possibly might be the link there to give us some contacts, appropriate contacts, so we can drop Sharon a line as well. Certainly, if there's anyone that anyone knows that within any organisation in the city that might be appropriate, then please let us know.
Thanks, Chair.
Councillor Taylor.
Thanks, Chair. Last comment of the night, I promise. Just going to say I really support what Councillor Bass is saying there. I think it would help. I mean, one thing it'd be interesting to explore, I don't know if you can do this as chair or if them services people can look into it, is if the council can sort of use its comms department to advertise upcoming meetings and what's going to be on that agenda. So you can almost see a tweet that says, would you like to talk about your dentistry experiences? If so, in 10 days' time, this is an opportunity. And equally, and I kick myself for this before Health Scrutiny almost all the time, we all have a bit of a platform to chase people up and say, oh, this meeting's coming up. I know we're all mad busy, as is everyone, but I think that's spot on. And it would bring Scrutiny to life a bit more, because don't know about you, but pre-pandemic, Health Scrutiny was really tasty. It's got a bit dry since, dare I say. Forgive my use of language, but yeah, I think it would be really helpful.
That's actually a really good idea, potentially using some sort of council social media to raise some interest. Councillor Oak.
Thank you. On another subject, earlier on it came up that there was going to be a report to try to get the benefit costed for early intervention that the university was working on. So to look at that when that finally is done.
Yeah. And so that we can possibly add that into the general work plan, but with officers suggesting, you know, appropriate time when that might be to bring forward. Same with the local area coordination. Yeah. Anything else, members? No? I don't have any other business this evening, so thank you very much.